Okay, thank you very much.
Well, Martin agus fáilte go cynniu bhúrs. Good morning and welcome to this meeting of the board. And welcome to all of the board members, but also to members of the public and of the media who are accessing the meeting virtually today. Just to remind you that the meeting is being recorded for future upload to our web, and to remind board members and participants to use the show hands facility if you want to speak at the meeting rather than the chat function. Now, before we start our meeting, I want to place on record our thanks to Kate Patience-Quate, who's actually not with us today, but who has been very ably acting as nurse director since November of last year when Heidi stepped down. Kate is stepping aside from that role from tomorrow, and we are very grateful to her for her input and a thoughtful contribution to the board over the last few months. At the same time, I would like to welcome Louise Bussell to her new role as our substantive board nurse director. Louise formally takes up her new role tomorrow. She's a familiar face around the table, and we look forward to working closely with Louise in her new role. I'd also like to record the board's congratulations to Andrew Kent, a trauma and orthopedic surgeon at Regmore, who was selected for the King's first ever New Year's Honours list, and who has been made an OBE for his services to UK and health and support overseas during the pandemic. This honour was conferred just weeks after he had won the Global Citizenship Award at the Scottish Health Awards of 2022. We're very proud to have colleagues of Andy's calibre and distinction, and we congratulate him on receiving both of these very special recognitions. And finally, I'd like to extend the board's congratulations to Dr. Ian Kennedy on his election to the position of chair of BMA Scotland. Many of you will know Dr. Kennedy, a GP from Inverness, who has been a member of the board's GP subcommittee and area medical committee for several years, and I think was on the board at one point as well. So congratulations all round. Apologies, Ruth. Do we have any apologies?
Thank you, Boyd. Yes, as you mentioned, we have an apology today from Kate Patience-Quate. We also have an apology from Fiona Hogg, and Gay Boyd is here today deputising for Fiona. And also I'm aware that Brian Williams, although he's here just now, he'll need to step out for a little while this morning and then return. Thank you.
Thank you. And declarations of conflict of interest. Are there any declarations? Alistair.
Yes, thank you, Boyd, and good morning, everyone. I had considered making a declaration of interest through my connection as a Highland councillor. However, having applied the objective test and taking into account my position in relation to the items on the agenda, I feel I don't need to do so. Thank you.
Thanks, Alistair. Any further declarations? Okay, we move on then to the minutes of the meeting of the 29th of November. And just to ask for accuracy, pages 1 and 2, 3 and 4, 5 and 6, 7 and 8, 9 and 10, and 11. Anne.
Good morning. Sorry, Boyd. I'm not quite sure what's going on this morning, but my screen has gone completely blank. So I can hear you, but I can't see anybody.
Oh dear.
And
Are you up in the northwest?
Sure yes. So
we see you now. We can see you.
Okay. Sorry, just one small suggestion for the minutes at the bottom of page 4. The reference to advocacy services, the second last bullet point. I think probably what I said was careful thought should be given to the commissioning of advocacy services, especially in blood, from then on. So,
right. So inserting the word to the commissioning of.
Yeah.
Advocacy
services rather than process.
Okay, I'm sure Nathan will capture that. Are there any further corrections to the minutes? If not, are we happy to adopt these as an accurate record of the meeting? Thank you. And we have a list also of on the action plan. Are there any updates from that, Ruth?
Thank you, Boyd. So no, there's nothing additional to what you can see there in front of you. There are 4 items that are proposed for removal from your current action tracker. The NTC report was considered at the last board meeting and will be included as a standing item for future meetings. It's also on this agenda too. Recruitment for the NTC was referenced at the last board meeting, and the information was provided to Bert during December and to the remainder of the board yesterday. You've received briefings on the budget challenges relating to adult social care recently, and the changes to the risk register, which were agreed at your last board meeting, have now been made. So those particular entries on your action planner have been taken down.
Okay. Are there any matters arising from the minutes that anybody wants to raise at this juncture? If not, can we move on to item 5, Chief Executive's report, and get an update from Pam?
Good morning. Good morning, everyone. I'm probably going to do more of a generic update this morning, because you'll see from the papers today and just generally where we're at in the year, we've got a huge number of challenges ahead. But I wanted just to start off by just acknowledging the whole workforce in terms of how they've worked over the winter so far. And December was a particularly challenging month for everybody, and right across health and social care, right across our patch, as it was for other boards. And I think it's really important just to place a formal thanks to our workforce for the dedication and passion in the toughest of times that they have displayed and taken us through this very difficult time. We're not obviously out of the woods, but I think it's important to just acknowledge I actually have touched base with a few teams, and I was in Raigmore yesterday. We talked before about the new escalation and decision making arrangements that we'd put in place as part of our winter plan, with it particularly in the first instance in Raigmore, and we're working at how that spread across certainly the Highland health and care system. And we have certainly had feedback that has made a huge difference for people, knowing that we all know and can see right through to the exec team and others what is going on in the system at any given time in the day. And I think that gives assurance. And I think that also is, because it's an objective measure, it also helps people be really clear about where we are at any given time. And we will continue to build on that system and refine it in terms of the decision making and the actions that people can take, which means they don't have to go around looking for people for decisions. They know what needs to happen. And the feedback certainly yesterday was that people had found that really helpful and would continue to build on it. So I think that's a really important thing to understand. I guess looking forward to this year, and as I said, as you'll see from many reports today, we are certainly have many challenges ahead of us, as we have done in recent years. And that rebalancing, recalibrating of our system is significant. And as an exec team and as leaders throughout the system, our focus has to be on the art of the possible, the changes that we can make in order to allow that balance to come back into place. Because of course, as we know, the performance and the challenges that happen through unscheduled care has a big impact on our unscheduled care and how we're able to perform operations and bring people off our waiting list. So we're very, very focused on that and the planning around how we get that in a more reliable state. That's not to say that we haven't continued to deliver at a level, but certainly not at the level that we are looking for. And our teams are really keen to get that addressed as well. So I think from that unscheduled and scheduled care perspective, that will be a massive focus for us as we look ahead. In women and children's as well, we've obviously got work to do, and we'll see that when we get to the performance report. We continue to work harder in CAMHS and NDAS, and we are looking at how we again strengthen the relationship into the integrated children's services that sit within Highland Council and really get that early intervention arrangements to the best they can be. We also clearly are on a journey of trying to improve and stabilise our maternity services, where there have been significant workforce challenges, particularly around the midwifery workforce, and how we ensure that we get the right balance between midwifery-led births in our community midwifery units and those that need to come into a consultant-led arrangement. So we, as you know, will be coming back with the kind of full business case around the improvements that we wish to do to maternity services at our next board meeting, and we will go through that in a development session before that board meeting. The Cabinet Secretary has not endorsed Model 4, as you will probably know from the pre-Christmas announcement, and so work continues to understand and have clarity on the expectation. But from our perspective, that journey and working with Scottish Government to improve our maternity services has that commitment, and we will continue to do so. And as I say, we'll talk more about that at the next board meeting in a more formal way. So lots of work going on in that space, and a real push to understand the staffing needs that we have, and also how we work with NES, National Education Scotland, and our universities to get that right workforce. And of course that applies across all of our areas, from Argyll and Bute right up to the whole of Highland. I think just the last part, obviously we're going to hear about the National Treatment Centre today, and that's hugely exciting. That is a massive piece of progress and a great prospect to have such a facility in our midst. And I'll leave Debs to go over the detail of that. But I think to acknowledge that and with Debs and all the team around it, including facilities and estates, that this has been a sterling piece of work, and taking us on a really positive journey to having a fantastic facility and a very clear operating model. And that will hand over to Catherine and our team in the coming weeks. So more general this morning, Boyd, rather than specific, but I think it's important just to acknowledge at the start of the year where we're at, and we have a lot to do. We're certainly going to have a busy year. Thank you.
Another one. Okay, thanks, Pam. Any questions for Pam on any of the points she's covered, or indeed on anything else you want to ask Pam about at this stage? You'll be coming back with another report on maternity at the March meeting. I don't see any hands up, so we can move on to next item of business, item 6, which is the dual language logo and branding. And Ruth Fry is going to speak to this. I think she's going to speak in English.
I'm afraid so, Boyd, yes. Although I'll try my best on the pronunciation. Thank you very much for the introduction. As the board can see, we have brought forward, I'm very pleased to have brought forward a paper on some progress towards us having a dual Gaelic English logo. So that is something we committed to in our Gaelic language plans, both our original plan in 2012 and the follow-up one in 2018. We're now, of course, onto our third Gaelic language plan. The NHS Highland logo, like all of the NHS Scotland logos, is owned by NHS Scotland and ultimately Scottish Government. So we've been in discussion with them about that change for some time. And in fact, there was a review of all of the branding due, which is one of the reasons why it's taken a wee while. However, more recently, they did ask us to submit a business case, which we did. And I'm really pleased to say they've come back with full approval of that, including approval from the Cabinet Secretary. So the next stage then is for the NHS Scotland's design team to produce that logo for us. They'll do that for us and provide it through to our designers in the medical illustration team, along with guidelines on its use, and then we'll be able to roll it out. That will be a gradual rollout, so we'll be replacing things as they come up. We won't be going around changing all of the signs or vehicles straight away, but when they come up for renewal, the new logo will go on, and of course we can start using the digital version straight away. So I'm really pleased to say it's a key commitment from our plan in terms of the visibility of Gaelic, and that we serve, of course, a significant Gaelic-speaking population, both in Highland and Argyll and Bute, and of course we also provide a number of services to people living in the Western Isles. So this will bring us into line with a number of other local and national bodies who also have dual language logos, and I'm happy to take any questions on that from the board.
Thank you, Ruth. Philip.
Yeah, no, it's good to see or good to hear that. I just wondered if we got any indicative dates about when we're likely to see the first version of the design of the logo.
So yes, NHS Scotland were actually in touch with us yesterday around the exact wording, the exact translation of the Highland part of our name. We got back to confirm that to them, and I know they were very keen to get something made very soon, so I'm expecting that imminently.
And this will bring us into line with the Western Isles Health Board, which already has a bilingual logo. Gaynor.
So yeah, I just looked at the Western Isles logo, so I'm assuming that our logo will be in a very similar vein.
Yes, that's what we would expect, that it will have the traditional NHS in the wings at the top. It will then have the Highland in Gaelic, followed by Highland in English. It's likely that the Gaelic will be slightly smaller just because there's more letters to fit in.
Anne.
I had a couple of questions, Boyd, just one on the detail. Ruth, I just wondered, I mean, it may be something to do with the conditions of funding, but in terms of the support that we've got for signage at Raigmore and Ascent House, I just wondered if rather than Ascent House, it would be better to start with another patient-facing facility, such as the hospitals in Broadford, for example. But there may be a reason why it's Ascent House as well as Raigmore. Sorry, I can't remember what paragraph it is in the report. So that was my first question. I don't know if there's enough.
I'm not sure if Alan Wilson is on the call, if he's able to answer that from the estate's point of view, but certainly my understanding is that as new signage is rolled out, it would have the new logo added.
You're on mute, Boyd.
Apologies. Thanks, David. Apologies, Anne. I lost that contribution because my connection went down temporarily.
Sorry, I think Alan's wanting to come in to answer my question.
Okay, Alan.
Yeah, thanks, Chair. Thanks, Anne. Yeah, once we have the design done in the size, then we'll have to look about. But I would agree with what Anne's suggesting. All new signage will incorporate it right away, but obviously there's a cost involved in doing the other signage. So once we get the design and we can see how we can even retrofit it and that, we'll maybe be able to do some quicker than others, Anne. So it's something that we'll pick up as soon as we've got that design.
And there is funding available, I think, Ruth, for some aspects. Anne, did you want to come back in?
Okay, well, yeah, I'm happy to follow that, for Alan to follow that up. It was just that, it mentioned that Rakemore and Ascent House would be the first, and I just thought it might be better than Ascent House to start with another patient-focused facility, but that's fine. I had a slightly broader question, which I hope, Boyd, is not strictly a logo issue, but it is, I guess, a branding issue. I just wanted to take the opportunity to ask Pam whether we were continuing to pursue with the issue about getting university board status.
Yes, Anne, we are. We're in the process at the moment at looking at our MOU with the University of Highlands and Islands, and I have been in discussions with some colleagues that have achieved that status and be getting some guidance about how the route to that. So we absolutely are keen to get there, and it's about creating the kind of evidence base and the right relationships for that to be justified.
Thanks. Anyway, it's great to see that we've got the approval for this, and looking forward to seeing the new logo. Thanks very much.
Has Boyd dropped off?
I wonder if we've lost Boyd.
I think I'm just looking down the side. I can't get my thing to move.
I think he's gone temporarily.
Okay. Anna,
Do you want me to? Are there any other questions
Alan,
on the logo? I see somebody's hands up, but I can't see who it is, I'm afraid.
It's Alex.
Okay, Alex.
Yeah, thanks, Anne. Yeah, it was about the NTC and the signage there. Alan, is the signage in the NTC going to be bilingual? I know you've got to wait for the logo, but has anything been done on that, or again, are we going to have to replace the signage as we go?
I would have to come back with you on that. I'm not sure what was. I would suggest it wouldn't be, because it would have been agreed a way back at the design. But the NTC has been a wee bit different too on the campus, because we've had to adhere to the university's signage plans too. So that's something that we've just got an agreement on just now, Alex. But I'll be able to feed back via Ruth that if we are doing the bilingual there, or if we weren't able to catch it at time. I'm not the son. I'm not sure of.
Apologies again. I got knocked out. I think the wind is affecting connectivity in this area. Any further points for Ruth on this? I think I should just acknowledge that when Pam and I spoke to the Director General, Caroline Lamb, and to the Cabinet Secretary, Humza Yusuf, way back at the opening of Badenoch and Strathbay Hospital, that they were very receptive to the idea. It's taken a little time to get to this point, but we had a fair wind, I think, at the highest level in the NHS for this. So, and I'd like to thank Ruth and all others involved, Nicola Thompson particularly, who's been helping us with as a Gaelic Development Officer, and for all their work on this front. So thank you, Ruth. And this is just for noting at this stage. Move on then to a integrated performance and a quality report. And over to you, David, to orchestrate, and I hope your connectivity is better than mine.
I'll do my best. Thank you, Chair. Good morning, everyone. You'll have a copy in your pack of the IPQR for our January board this morning. That largely covers data up to the end of November. And thanks to Lorraine and her team, as well as my executive colleagues who have submitted information for the report. I'm sure you'll agree with me that it's becoming quite a comprehensive report, and thank you all for your continued feedback around it so that we can enhance it and improve it as we go along. Just a reminder that for many of you, you will have seen this as it's gone through the subcommittees of the board. That's with clinical governance, finance, performance and resources, and staff governance committees. And so it comes today as the combined report. A couple of highlights for you. You'll see in it updates with regard to our vaccination programme, particularly around COVID and flu, and the vast majority of that programme is now delivered, but there are still delivery that is ongoing. Uptake for those is probably lower than what we have seen previously, particularly for COVID boosters, but is in line with the national picture. And so the update is provided. Some improvements that we're seeing in the data, drug and alcohol waiting times has improved and is still in a positive trajectory. Our CAMS performance, which has been an area of focus for us, has started to improve. Still a long way to go, but is on the right trajectory again. And as Pam has mentioned, our ED performance has held relatively steady. I know the data is only up to November, but that has continued through December and into January, and that's great credit to the teams who have rallied round to provide that level of performance despite the pressures that we've all experienced through the winter period. And while it might not be as high as what we would anticipate or like it to be, from a national point of view, it is favourable in that regard, and credit to the team who have been working on that. Scheduled care still remains a challenge for us to have our full scheduled care programme up and running, but we still are making progress despite the hospital pressures. Cancer services there's two halves to the picture. And 31 days performance has shown further improvements, which is welcome news. However, our 62-day performance has deteriorated. And before I open up for questions, I'm going to invite Catherine to just say a few words around that, and then we'll open up for questions after that. Catherine.
Thanks, David. Yes, our position around our 62-day specialties is in particularly challenged across our urology and colorectal pathways. And we are looking at aligning our cancer performance recovery board as a part of our scheduled care performance recovery board, and indeed prioritising cancer patients ahead of any other form of recovery. So ensuring that these patients get the financial prioritisation as we build and develop our financial and performance recovery plans going into this coming financial year, but also looking at ensuring that every specialty and all diagnostic areas are prioritising cancer patients in their journey. That's a significant challenge. The number of patients that are coming onto our cancer pathways are increasing, and that is something that we had anticipated as we started to recover from the pandemic. We know that we saw a drop off in referrals for cancer and onto urgent suspected cancer pathways. and indeed that has picked up over the latter half of last year. So we're looking at readjusting our approach to ensure that this dip in performance across these particular pathways is prioritised, and do anticipate that getting us to where we want to get to in terms of our 62-day cancer performance. But as David says, the 31-day performance is looking favourable and in line with national recovery also. Thank you, David.
Thanks, Catherine. I'm happy to open it up to questions, colleagues. Alistair, can I come to you first? Oh, Alistair, you're on mute.
Yeah, people prefer me on mute. In terms of the report, when you introduced it, is it November? It would be useful to hear a bit about how long it takes to get data processed through the system in order to get to the report. So a little bit about the mechanics of it and what we could perhaps do to get more timely data, if there is anything that we can do to get more timely data. Because, you know, it's tricky as a non-executive director, because we don't want to say something's doing really well only to find that the trend since November is going the opposite way, or vice versa, that you know, something is doing badly and it's been totally returned round. So I don't know, Catherine, if you're able to give some thoughts around the cancer, which is of particular interest to me on our performance, as to what the feeling is since November to December and through to almost the end of January, as to what things are looking like. And I don't know, David, is there any way we could look to make predictions on some of this data moving forward? Obviously, it wouldn't be suited for all of it, but for some, it'd be good to get an estimate of where we might be next quarter on it. But I think every time I look at this integrated performance and quality report, I see something new in it I like. I think it is the way forward. And I think maybe the next refinement to think about is how we could start thinking about predicting maybe the quarter ahead as to where we might be on some of the key areas that the board is concerned or passionate about. Thank you.
Yeah, thanks, Alistair. In terms of the data, that for many of the areas, the data is readily available. That's not the issue. What we chose from a governance point of view is to ensure that the subcommittees of the board have the opportunity to review the relevant data, and that therefore takes time. So that effectively is through the December period into the early part of January, before it comes to the board as a consolidated report. So the board can see a report that has gone through the subcommittees. So there is performance data that is available, and it may be that if the board members find it helpful, the status and the more frequent reporting can be, for certain highlighted areas, be shared with you so that you can track those critical areas on a more up-to-date basis. But from a governance point of view, then the data is presented from a governance perspective, having gone through the subcommittees. But Boyd, did you want to come in on that point?
Yeah, you beat me to it, David. Yeah, so the function of the board will always look at some of this data in arrears, in effect. But for instance, as chair of Clinical Governance Committee, Alistair, you'll see the data that's closer to the current timeline, but because it has to go through the Clinical Governance Committee. And as chair of Clinical Governance Committee, you can also, if you require, get access to data and even more live. But there's always a little trade-off in ensuring accuracy and that all factors are in. So even for the Governance Committee, the data needs to be made right so that the Governance Committee will see, and below it there will be other groups within, particularly in this case acute and within the cancer meetings, that will be looking at that as part of the process before it comes the way of the Governance Committee and then up to the board.
Thanks, Boyd. Okay, thank you. Gaynor, can I come to you?
Thanks, David. Just a quick set of questions about the NDAS service. I remember when that was launched at the board at the time, in consultation or co-production with parents, and it was a real flagship service that we're launching. But obviously, it looks like demand has outstripped capacity, and I just wondered what we were doing to manage that demand. And if you look at what we're doing in terms of CAMs, Catherine, you've talked there around in the piece on the sheet around having a strategic implementation plan and a view of clinical models. But I'm not clear as to what we're doing with the NDAS service. So I just wanted to get some clarity around that, thanks, and what we do in terms of managing that demand.
Thanks.
Yeah, absolutely.
Again, come in, Catherine.
Yeah, thanks, Gaina, for the question. So what we are doing is taking a similar approach to the CAMs. We have reviewed the NDAS service, and indeed we've taken some action to appoint a unified sort of service manager. That is something that the NDAS service has struggled with for some time. Obviously, NDAS sits across the services that have been set up in the Highland Council area. So looking at the HP professions and those professions and how they all come together as a multidisciplinary team to meet children's needs in terms of that assessment process. And that heavily relies, for obvious reasons, on our CAM service as well. So we are working in a slightly different way. We have new leadership in our Women's and Children's Directorate area, and we are considering how we bring the NDAS service in as a part of the integrated services that we're working with our colleagues in Highland Council on to ensure that these patients are prioritised in the services that are required to respond. So it's a very, very similar setup to our cancer service, where it's reliant on a number of services to prioritise these children within the overall workload that they have to deliver and ensure that they are up the scale in terms of that response. So we have some detailed work coming forward, Gaina, in terms of that, and I'm confident now with our leadership that we have set up in those areas and our more closer working. And in response to the recent Children's Services inspection, you know, we have a much more integrated way forward that will support the needs of these children better and address those issues on those waiting lists. So happy to come back to you in more detail if required around that. But that's the general approach that we're taking to ensure that we take that holistic approach that we've taken in terms of bringing our CAM service together.
Thanks, Catherine. Alex, can I come to you, please?
Thanks, David. A couple of questions. One for Tim. The vaccination programme. I'm assuming that's us now from the annual point of view for COVID and flu. Will there be a spring or a spring booster programme this year, or is that not planned? Are we going to move now into an annual COVID thing with flu? Rather than anything in between. And then a quick question for Louise on delayed discharges. I'm looking at the chart at the very bottom right of the page, and the delayed discharges look like they're back above where we were pre-COVID. So 2017, 2018, 2019, the numbers all look the same, but we're doing an awful lot to try to, I know we're doing a lot to try to improve the situation. Have we got a feel for how long it's going to take before some of the things that's written there are going to start to bring forth fruit, or are we kind of pushing against it and hoping for the best rather than planning for the best? Thanks.
Thanks, Alex. Tim, can I come to you first, please?
Yeah, so just a couple of things. And before I ask you a question, Alex, just to say that since the publication of the IPQR, our vaccination rates have actually risen very slightly, so that both for COVID and flu, our rates are now slightly above the Scottish average, which is good news for overall coverage. We're still waiting for formal confirmation of programmes for later on in the year. What we expect based on the Joint Committee for Vaccination and Immunisation advice is that I'm expecting a limited programme for the particularly vulnerable people for COVID vaccinations in spring, but then the main programme as probably an autumn programme, which should be in line with the regular immunisation, regular influenza immunisation. But we should get confirmation of that very soon.
Thanks, Tim. Louise, can I come to you, please?
Thanks, yes, and Alex, as you say, there is a great deal of work going on in the background, and certainly some really positive pieces of work being led by the likes of Joe McBain, who's leading on Discharge Without Delay, and we've developed new flow roles across the entire Highland area that is very much about how we link in with all of the services from community to acute and have pathways that sufficiently work effectively. It does feel like we're on the cusp of improvement in many of those areas, and lots of things that are coming together now. However, I will put a health warning on that in terms of the delays relating to care homes and care at home, because they are our real challenge. We have got capacity issues in both areas that we've got to try and fundamentally tackle. So whilst we're doing a great deal of work to try and smooth the pathway out and make people go to where they need to do as soon as possible, there is that caveat that we've got significant work to do to try and fundamentally change the opportunities for people to move out. So that piece of work is going to take longer. I wouldn't like to necessarily give a timescale on that because it is tricky. And with all of the other issues going on around care homes and vulnerability of care homes, it does leave us in a more challenged situation. I would say we have had a good response from the independent sector around use of interim care beds. So from that point of view, I think it's hopeful. However, it's small numbers.
Thanks, Louise. Susan, can I come to you?
Thank you, David. And a couple of points about the early detection of cancer rates that we've got, but I also wanted to just support Alistair's comment about seeing some more kind of forecasting and predictive data where it's possible, just so that we can then track back and see where we're going. The point about the early rates, I noticed that we're below average, and so is, you know, a lot of other health boards are in the same place. And firstly, I wondered, are there any targets or guidelines here? You know, where ought we to be? Because it doesn't feel comfortable to know that we're all very poor at doing this. And I wondered if maybe we could look at using the control charts that we talked about at a previous development meeting to show some of our data. Where are we within a range? And the second point is, I realise it's obviously likely to be a combination of diagnostics and awareness. So could somebody say a little bit about what we're doing on both of those things? Thank you.
So Susan, it blanked out on me just for a second there. You talked about forecasted data, and what was the other item that you mentioned?
Sorry, I said I support what Alistair was saying about forecasting data. On the early diagnosis of cancer, could we use control charts to say where we are? Is there a target or a range that we should be meeting here? And the second point was about, you know, given that the rates are low overall, and it's likely to be a combination of access to diagnostics and awareness, could someone say a little bit about what we're doing on both of those things? So I know they've both been commented on in the reports, but just to say something about the activity that's going on there. Thank you.
Yeah. Catherine, can I come back to you on that, please?
Yeah, absolutely. So you're absolutely right. And the challenge for us around the 62-day and the 31-day targets is that it's not until all patients have passed through those pathways that we can actually measure that performance data, because they're based on actual patients that have actually gone through all of these cancer pathways to measurement point. The point about the predictive measures is quite right, and that's certainly something that we want to focus on. So are we sure that every patient that has been referred onto an urgent suspected cancer pathway has actually been through the diagnostics within the standards that we set? And there are subsets along those patient pathways that we can measure. So there is a predictive performance measure I think we could get to. I think that's also going to be educational for everybody to understand the volume of patients that actually get referred onto these pathways. That puts a huge pressure, particularly onto our diagnostic pathways. So we really need to understand the conversion rates, how many of those actually become cancer, and are we being precise enough in terms of the diagnosticians that are deciding whether or not these patients go on to urgent suspected cancer pathways at the outset. So there's something for us in there about how well we use the capacity that we have available to us, and that's all of the work that we're planning to take forward. Separate to that is, are the population aware that if they get in early and raise concerns if they think they have symptoms and are getting access at the front doors? And that's the front doors in the widest sense, not the acute front doors, but actually our primary care front doors. And are those pathways working effectively? So there's a fair, I don't have the answers for you today on that, but there is a huge amount of work going on, and you're right to ask those questions, Susan. That is IPQR for us to have more patients coming onto cancer pathways. Is that to be expected given the demography and the ageing population? I'd suggest that it is. What does it actually mean? How are we applying realistic medicine as well along these pathways? And what are the right things to do in terms of supporting people even after diagnosis? So we're looking at a range of measures on the range of fronts in terms of the quality of the pathways. I hope that helps answer and respond to that question, Susan. I don't have a blueprint that I can give you right now or any specifics around that, but certainly be reassured that we are working hard on those fronts, and it is a very complex picture.
Thanks, Catherine. Boyd, I don't know if you wanted to come in and comment. I know you're involved in a number of the regional and national programmes around cancer.
Yeah, thanks. I think the question was around the early diagnosis and the data that's there. It's Scottish Government strategy and policy, and it's emerging. Early diagnosis is one of the aspirations. A couple of health boards have had investment and been able to create early diagnostic centres, which are usually part of the existing fabric. And the aim is to pick up people at an earlier stage of the cancer. So it's a work in progress nationally, and it's reflected here because in a sense, the direction we need to travel in the next 5 to 10 years is to pick up more cancers at an points made about access to diagnostics is part of the answer. Some of it is also about people recognizing they have symptoms and need to go and get checked out. The flip side of the coin, unfortunately, is that to get early diagnoses of cancer, you have to investigate a lot more people who will turn out not to have cancer. So the return rate on the number of investigations is less productive in terms of the numbers you pick up. The argument being, though, if you pick up early, better chance of a longer of a cure or a better progress with the disease. The other challenge in that is that brings us back to national workforce issues, which are reflected in Highland as well. We simply don't have the workforce and the infrastructure to supply all of the diagnostic and other pathway elements required for early diagnosis. So I think while it's there and it's useful to see where we stand, I guess the other side would be, are we not diagnosing early stage cancer as well as rest of Scotland? It looks like we're in the pack. So the question, if we're not below standard or below average, the question has to be then, how could we improve? So although the metrics presented, I think it really picks up in the conversations around the Cancer Board and Cancer Recovery Board and about what we do next to enhance cancer services and community services, which are aimed at finding people with symptoms and getting them into the system earlier. So I think one to watch, but a slow burner.
Thanks, Boyd, and thanks, Susan, for the question. Muriel, can I come to you, please?
Thank you, David. Urology was mentioned as part of the recovery as well, and we know that there are national challenges for access, but are we able to access other boards for services, for instance, like urology? And I presume there is a plan ongoing for that service as well. We know there are shortages of personnel there too. Just an update on that, please.
Thanks, Muriel. Catherine, can I come back to you?
Yeah, sure. So we are engaged through the Centre for Sustainable Delivery, and prior to that, previous government initiatives, and indeed, due to the shortage of urologists in particular, we have developed specialist nursing roles and looked at how we can enhance the workforce locally. So I think we're doing all we can on those fronts in terms of engaging with other board areas. Yes, we do deliver some of our robotic surgery for cancer patients through Grampian, and we're also relying on Lothian for some support to our cancer pathways as well. So we're looking at those. We're also looking at access to PET CT and PET MRI scanning, and whether or not we need to think about developing those services locally. Indeed, if we do go down that route, that takes us into the need to update our capital infrastructure and our buildings and accommodation for cancer. So the strategic work that Boyd has referenced is really important and key to us as we start to move things forward. Hope that answers that question, Muriel.
Thank you. Thanks, Muriel. Jerry, good morning. Can I come to you?
Morning, David. Thank you very much. Probably maybe just anticipating some of the discussions we're going to have later on in the agenda. All of my questions or comments are really around the public health theme, so they're probably all directed towards Tim, and he can, if he's going to cover them later on when he discusses his annual report, that I'm absolutely fine with that. I was looking at the ABIs, and I just wondered if we could have some comments on the data there in North Highland. They'll be primarily coming from a primary care setting with no secondary care. ABI has been recorded, and I'm assuming nothing at all from Argyll and Butte. So I would just like to get some feel on that. Following on the theme of detect cancer early, I just wondered if Tim's got any thoughts nationally, or has been discussed nationally. Are the screening programmes now back up and running at pre-COVID capacity and output limits? Because picking up on Boyd's point, actually, if we're going to have a successful screening programmes, we need people participating in the screening programmes first of all. So I think that really is quite key. And I think another couple of points I had there was just in relation to smoking cessation. And again, this might be one for when we discuss the DPH report. Nationally, performance on smoking cessation seems to be poor, and I just wonder if it's time for a rethink on either the interventions, or are we putting enough into the interventions? Because I see in the commentary there's only 3 out of 15 boards actually achieving the target, and I think Tim's report sets out very clearly the benefits of a successful smoking cessation programme. And I think finally, and apologies if I've missed this in earlier discussions about COVID, I just wonder if Tim had any thoughts on why across the board, and I don't just mean for Highland, I mean nationally, COVID/flu seems to be sitting in the mid 70% ranges now for uptake rather than the high 90s and I appreciate flu has always been in the lower level of that range. So just a few thoughts there on the public health issues. Thank you, David.
Thanks, Jerry. Can't do better than come to Tim and let you address those ones, Tim.
Thanks, David. Right, I'll try and get through them quickly. First of all, on alcohol brief interventions, this was raised as other issues on the IPQR at the Performance Oversight Board. I think it was last week, and we were able to look at that in a little bit more depth, and there are a lot of actions that are needed. It is, and it was pointed out at the Oversight Board, actually quite good news that there's such a lot of activity within primary care. So I think that we mustn't forget that, but there are areas that certainly need attention. There's a recovery plan being put underway for Argyll and Bute, because it clearly there's further action that's needed there in order both to do the interventions and to record the interventions. And we've got a legacy from recording of COVID and data systems within the acute sector at Raigmore, whereby we need some changes there. So the practical things with around alcohol brief intervention, the whole approach is being to alcohol brief interventions is being reviewed nationally, and one of the public health consultants from NHS Highland is actually chairing the group that's looking at that. So we're trying to maximise the efficiency and effectiveness of alcohol brief interventions, but certainly there's a lot more that we need to do with that. In terms of screening, essentially screening's back up and running as it was before COVID. We do have certain challenges, which are similar challenges to a lot of the things happening in other healthcare provision around the availability of staffing and skill mix, which are causing challenges, but overall we're doing reasonably well. But I think there is again a lot more we can do, perhaps mostly apart from screening, to make sure that people do recognise symptoms, and do present, and also do have lifestyles that hopefully will reduce the chance of developing cancer. We also need to be particularly concerned about health inequalities, because for pretty well everything, including screening and all the things in the IPQR, people in the poorer areas are more likely to have worse outcomes. So we've got particular work on screening for that. There are programmes around early diagnosis and awareness that are done nationally, and I think we do need to look at what works, what's effective within our particular local areas, and the evidence of actually what really works. In terms of smoking cessation, I think I'll return to that as you were suggesting within the annual report. But one particular thing to say is we do, I think, need to revise our approach to some extent, but also to think more around tobacco control and the whole smoking and tobacco picture. As it happens, the indicator which is used nationally, the one on the IPQR, is one that takes into account health inequalities, but it's one where the actual numbers are very small. If we think that we've got 20% of the whole population, adult population, smoking, then that's quite a big mountain to tackle, and only a small proportion of those would ever likely to quit through the services that we provide. So they're important, but they're only a small part of that. And I think we need a serious attempt to prioritise tackling addiction to tobacco. And finally, in terms of COVID and why COVID rates are lower, I think there's some degree of fatigue and people feeling that they are protected and that COVID's gone away. What we do find is that the older the people and the more, particularly older, I suppose, not just more vulnerable, but older people are more likely to have higher rates of vaccination. I think there's that perception of vulnerability, which will be true. Also, knowing people who've suffered severely from COVID, and also perhaps that working age adults, other activities may get in the way more. So I think it's multifaceted, but I think mostly it's simply around just a general behavioural fatigue and feeling that perhaps well, I've had a couple of vaccinations, I'll be all right, and that working through the whole population.
Thanks, Tim, and more to come in the report later. But I think that's it. Hopefully that's helpful. Thumbs up from Jerry. Gaynor, can I come back to you? Then we'll come to Anne, then Louise.
Thanks, David. I just wanted to take us on to page 146 of the report. Objective 3 are people, and it was really to Fiona, you flagged up there that sickness absence is now above 6% for the first time in NHS Highland, and at the same time, in the kind of turnover in November rose, albeit from quite a low level. I just wondered, in terms of going forward, if you've got any feel for the data for December and January, where that trend is going, and are those two things together seen as a bit of a potential red flag? And just lastly, you also mentioned that this last year, kind of March, April, there were a peak in retirals, and I just wondered again, you must have some information about who may or may not be retiring, and if we're going to have a similar peak this year in terms of kind of March, April, or maybe further down the line in later in the year. Thanks.
Thanks, Gaynor. Gay, can I invite you to respond to that, please?
Yes, thanks, David, and thanks, Gaynor. We have a bit of a problem in terms of our data because we reported November and January because that's how we can get the data on time. So we don't actually have Decembers and Januaries yet. However, you're right, we want to be keeping an eye on definitely the sickness absence and the turnover, and with the work we're doing around attraction and our promoting careers, we're hoping that we'll see a change in that. For sickness absence, we have dedicated resource that are supporting managers to work with our colleagues that are ill in the hope that we can improve our figures too. Part of that increase might be because we changed the way we record COVID. And so we'll need to see how the trends show for the next few months to see whether that will cover that. Retirals, we did have a peak in retirals, and I think we have the data, and we've been sharing the data with the areas in terms of our workforce planning. However, we've also launched the retire and return policy nationally, and we're seeing some applications come through from that. So I think we will see a number of retirements this year, but hopefully we'll be able to retain a proportion of them through that new process. Thank you.
Thanks, Gay. And I think that was one of the questions at Staff Governance Committee last time around, was around that additional scrutiny around that, particularly retire and return. And of course, that will show in the turnover, even though the people are retained and still working, as it were. But nonetheless, it's the data that's recorded. But thanks for the question, Gaynor. Anne, can I come to you, and then I'll come to Louise last. Thanks.
Okay. So first of all, I'd like to just support Alistair and Susan's point, which I also had noted for a contribution about the next sort of stage of development of our approach to the IPQR, perhaps focusing a little bit more on trajectories for improvement and whether or not we're achieving them. So just a support for that point. But it's not a question really, it's more a general comment. There's no doubt when we look at this data that it tells us that it's a system under significant pressure. But I think I'd like to go back to where Pam started her introduction and celebrate really the incredible effort that is going on across all of our staff groups to be able to, despite those pressures, still maintain a very impressive performance in many areas of our business. I think this is an item on the agenda where it's right that we're scrutinising where performance is not so good. And as a board, I'm sure we're all very sorry that some people will be waiting longer than we would wish, and some people will not have been seen as quickly as we would wish. But I've dipped in once or twice recently to just some of the seminars and the initiatives that are available to view on our intranet and things like that, whether it's the work that we're doing with the Centre for Sustainable Delivery, whether it's some of the personal achievements that Boyd referenced at the start of the meeting, whether it's some of the things that we see in our social media these days about the people behind the scenes that make such a huge contribution to our services. And I'm never fail to be impressed at what people are achieving despite all the pressures that are on them. So I just wanted to celebrate that and thank everybody for their efforts. We've got a long way to go, and no doubt there'll be new challenges ahead of us. But I think it's worth saying all that. But I do have a question as well around this, and I think Pam referenced that a key task at the moment is trying to keep the system in balance. And I just wondered, we've heard lots and lots recently about the issues around unscheduled care. I just wondered if maybe the team could say a little bit about how our clinicians are involved in the decisions about how we achieve that balance, and the efforts that are going into particularly protecting as much of our surgery as possible, because that's I think a side of things that isn't quite so prominently in focus nationally, perhaps in the media and things like that. So it would be helpful to hear a little bit about all the work I know is going on behind the scenes around that issue. Thanks.
Thanks, and thanks for your comments too. I think we classically manage by exception and concentrate on the areas that need our attention, but sometimes don't quite recognise the amount of work that goes in to maintain performance across the board. So thank you. I'm going to come to Catherine first on your question, and then maybe perhaps Boyd might want to add to that afterwards. Catherine.
Yeah, thanks again for the question and the comments, Anne. So we have unscheduled care performance recovery boards, and certainly within the acute sector, we have a dedicated unscheduled care performance recovery board, and that is really looking at working very much with our clinicians. They are engaged in that. Our Deputy Medical Director chairs that programme board for recovery and supports clinical improvement. So we're really working with our clinicians, feeding the information back to them around where they are in terms of performance and what can we do, how can we redesign and tweak patient pathways to help improve on that. So I think that has been very, very successful. In terms of our winter plan, we have looked at how could we keep elective activity going, and the clinicians have come up with a way of sustaining service through this winter period. And for the first time this year, we've seen elective orthopaedic operating continue throughout that winter period and sustaining that ring-fenced ward for our elective orthopaedics for those high priority cases. And indeed, the clinicians have found a new way of working that allows allows our elective patients to be maintained through that period, particularly those on critical cancer pathways, and our clinicians were at the forefront of driving that forward. We also have a scheduled care performance recovery board, and that is also chaired by our Deputy Medical Director. It has various subgroups working to it, and each of those subgroup areas are led and championed and populated with our clinical leaders and clinical staff, really looking at drawing on their expertise to reshape and take things forward. We are looking at the moment as to with all the challenge that we have in the system and the pressures on the system in terms of that wider flow for patients moving out to places external to the acute hospitals. What do we do over this period, and how can we work as effectively as possible? And indeed, our surgeons have been critical to rethinking some and reforming some of those pathways so that we can absolutely prioritise day case, and they're working and looking to work that has been taken forward and brought to us by the Centre for Sustainable Delivery. So our clinicians are absolutely at the forefront of this. As we move into financial recovery, going and looking at our plans for next year, we're working on ensuring that our clinicians are able to help us prioritise where we dedicate our financial capacity and how we make best use of that going forward, that balances performance recovery and financial recovery. So that is an area that we haven't gone into. We've been very successful, I think, in terms of the way we've worked around unscheduled care and scheduled care, and we want to build on that now around how we build a financial recovery programme that engages with our clinicians and brings them more to that front and centre and leading that financial recovery.
Thanks, Catherine. And Boyd, I was going to come to you.
Thanks. I think some of the question was about our clinicians involved, and I think Catherine has given a good answer to that. It's really, really important, and whatever involvement, we always want more. The clinical involvement, clinical leadership's really important. In terms of the balance between scheduled and unscheduled care, I think there is a real problem there. Right across Scotland, this is a challenge. The dilemma for every board is to keep the front door open, but also to look after the elective side. And I particularly focus on cancer and other types of treatment where they're not the immediate emergencies, but they're really important things where it affects persons' well-being and indeed their long-term outcomes. So that is a continual challenge. We have a finite resource, we have a finite workforce, we've got all sorts of extra safety and infection control measures and other challenges which we didn't have before. And it has to be clinicians in amongst all of that to manage the risks in that complex system, and they do that very well indeed. If orthopaedic ring fencing has been a success in last year, then I understand from my senior colleagues, and particularly in surgical, that the ambition is to extend ring fencing into other parts of the surgical community. So it's a better safeguarded approach, and that is being worked into what we do going forward this year. So we're taking each step carefully, though, because COVID and the comet's tail of it has been full of surprises, and you can never quite predict what's coming. But we absolutely need to have that clinical workforce right up the middle of how we run things.
Thanks, Boyd. Pam, did you want to come in?
Yes, please. Thanks, David. Yeah, I think, and I'm really pleased that you asked that question, because I think for our workforce again and for our clinicians, that sometimes is how they might experience the system, that they feel like they are set aside in that space very easily, and that is frustrating for them. I met with the general surgeons the other night, and really around the discussion that I guess Catherine's just set out in terms of how we work together and how we all understand the system together and how we try and rebalance, just as Boyd has said, because we really do need to. I think what was really important for them, and also for our orthopaedic surgeons, I've had similar discussions with them, is that they know that you know how tricky that is and how frustrating that can be for them. But definitely they feel they need to feel that connection with the board, the awareness that everybody's aware of where we're at. But certainly I did detect that kind of willingness to work together, but really looking for the support to get to a different place, because they're dealing with people firsthand, the emotion associated with that, the difficulty of either cancelling or not being able to see people that they know should be getting seen more quickly. So I think it's good to have had this discussion, because it's important for them that they know that you know, and that as a board we are taking that seriously.
Thanks, Pam. Okay, I'm going to come to Louise, and then we're going to come to Graham after that, and hopefully we'll wrap up at that point.
Thanks. Graham put his hand up during that conversation. I don't know whether it was on the same point before I move off in a different direction.
Graham, go ahead.
Thank you. Yes, thanks, Louise. Yes, it was a follow on from that. And it was about that, as Boyd referred to it, as a long tail that has left all sorts of implications and repercussions for us going forward. And we talk about recovery as if maybe 6 months or 12 months we'll be able to shake off all these kind of impacts and get back to where we were pre-COVID. But given that we've also had a conversation about how it is now, COVID is with us and it's here to stay, I'm just trying to get a kind of impression, and I know it's impossible to predict, but at what point will we have to just accept that we've got fundamental long-term structural impacts on how services are delivered, and actually where that will leave us? Because I guess I fear that if we keep talking about a recovery to some kind of golden age, that we're making a cross for our own backs. But sorry, a hard question, and really just trying to get an impression from our experts on that. Thank you.
Thanks. I think that's you're voicing a concern and a challenge that we're facing across the board, and the reality of it, it's not confined to any particular area, but right across many areas, from our community settings into our acute settings. I think for me, there's a couple of things on that. One is related to what the national guidance is that comes out to us, particularly around good practice of infection control. And there definitely remains a legacy of that, because the extreme of infection control would make it practically very difficult to deliver some of our services, and we've had to live with that. And it's getting the right balance between the level of controls versus the interaction and flexibility that's required to deliver services in the most efficient way. I think it's a good question. I don't think there is an easy answer. I could go to my colleagues, I'm sure, but I don't think there is an answer in all the discussions I've been involved in, Graham. What I would say is that we are in a better position now than what we have been. And I think we, just as you say, we will need to learn to live with COVID to some extent. And it's being able to be as cognizant of that, but also recognise that we have to be careful to restrict our delivery of services with no risk, but yet do that in as fast and efficient and as a high quality way as possible. And I think there are many people who are trying to get that balance right. So I think it's a one that we'll need to wait and see where that goes. That's okay. Louise, can I come to you finally?
Thank you. Yes, and I just wanted to highlight a couple of areas within the report. One, a positive story, and the other one is hopefully to give some assurance. Firstly, in relation to our psychological therapies work, and you will see from slide on page 144 that there has been significant improvement in our waiting times and our position nationally. And I just wanted to pay tribute to our Director of Psychology, Alison Turnbull-Dukes, who's been instrumental in leading this piece of work since she joined the board. She's very much focused. I'm conscious that she's a Highland-wide post, but she has very much focused on North Highland in the last year or so, but now she's turning her attention to supporting in Argyll and Bute too. And certainly she's made a huge difference in terms of the development work, new ways of working, considering how we do group work, and really engage in that importance of the voice of the service users within this. So there's very positive plans that we've submitted to Scottish Government, and I just wanted to recognise that really. There's a long way to go. We're not saying that those people on the waiting list aren't waiting longer than we would want them to be, but certainly the direction of travel is a really good one, and I just wanted to acknowledge that really. The second one is in relation to the information on slide 145, which is about our post-diagnostic support for people with dementia. And you will see from the information that's shared there that actually 21-22 Highland, North Highland had much lower figures than Argyll and Bute. So we wanted to really dig into that and understand. We had our mental health programme board yesterday where, funnily enough, we talked about the PT plan, and this was one of our two focus areas. And there is a lot more information behind that, which gives us good assurance in that previous years we've been at the 80+% within the whole of Highland. When we benchmarked 21-22, and funnily enough, Argyll and Bute is actually the outlier by being really high levels of data there, because when we looked at ourselves against other boards, most of the boards were around 48-49%. So we need to really look at what Argyll and Bute did well in that year, that across the boards we didn't do so well. But if for this coming year, we've got much more assurance that there's an improved picture. The Alzheimer's Scotland, who are working closely with us on this and actually provide the workers for this that join our teams, have got to a really good position around having no vacancies across all of the areas that they did. So we feel that we've got some good assurance that this is going in the right direction, and it was really just to highlight that to everybody.
Thanks, Louise. Good to end in that positive frame. So two positive areas as we conclude. Thank you all for your questions and your feedback. The questions and the angles that you asked them are really helpful for us, because we're often looking at this data and it's useful on a regular basis, and it's helpful just to get your views as well as adding to the overall governance of performance and quality. And obviously that's an essential part of what we do as a board. But thank you all for your feedback. And I've noted the requests, particularly around our the way that we present data, and we'll reflect on that and see what changes we can make. If you give us some patience as we try to make those changes, I'd appreciate it. But we'll certainly look to add more around trajectories, as well as looking at where control charts would be most apt. But thank you again. And Chairman, apologies, we probably extended the period to which we reviewed this, but I think we're slightly still ahead of time, but I'll hand it back to you now. Thank you.
Thank you, David. Thank you for conducting that session, and thank you all for the contributions. It was a very good discussion, I thought, of the report. I just want to associate myself totally with Anne's comments and Pam's earlier on about the difficult system pressures that we're facing at present, and to commend our staff for their performance in the face of such a difficult set of circumstances. So I would just want to reiterate our appreciation of what the staff do and what they have achieved and are continuing to achieve in the most trying of times. I do want just to pick up on Louise's point about the Argyll and Bute and the variation between North Highland and Argyll and Bute, which comes through in several domains. CAMS is another one, as well as post-diagnostic dementia and alcohol brief interventions are ones that struck me, but it would be good for us as a board, I think, to look internally at how how we can learn one from another in that regard. Well, we're coming up to comfort break now. I think we're going to break. We'll break now for the 15 minutes, so we'll maybe return at 11:10 after a 15-minute break, and we'll be all set to tackle finance after that.